Thank you all very much for your patience. And as I said, there may be a few little technical glitches, and we appreciate your patience and understanding when that happens. I didn't say if that happens, I said when that happens. Okay, first slide here, just a little bit, just to go through while people are still signing in. What you need to do, everyone, whether you want CEs or not, you need to sign in on an attendance sheet. Everyone needs to take the quiz and get at least a 80% passing score. Everyone needs to do the evaluation, please. If you want CEs, please include your license number on the sign-in sheet. Oops, everyone must attend the whole webinar, please. And then after all this, the paperwork will be scored and submitted here to the education department, and that the CE certificate will get to you once that stuff is sent in and processed. And any questions, there is your contact there at the bottom. All right, let's get going. My clicker is not going. Sorry, folks. I have to stand here. Okay, here we go. We're talking about nursing care and cardiac conditions, and especially for with a focus on the requirements of PDPM. Oh, there we go. My clicker's working. Yay. All right. So just keeping those hearts as healthy as we can. Here's what we're going to talk about. We're going to talk about atrial fibrillation, including symptoms, complications, treatments. We're going to talk about documentation, because that is how we prove what we earn, what we deserve to earn. Heart failure symptoms and complications, heart failure management and documentation, and then coronary artery bypass graft, the management, complications, and documentation. So you guys have been getting a few in-services about this whole patient-driven payment model. What it's about now is reimbursement to us as nurses and to us as Providence based on our nursing care. So our care and then documentation of our care must reflect that what we deserve to get paid, right? So we have to show that for each diagnosis, we are doing a proper assessment, proper care. Are we educating? What are people's response both to the care we're giving and to the education? Follow up all our communications, and then of course document all of that. A big thing is noting everyone, no matter what they're here with us for, what is their functional ability? How much can they do? And how much do we need to do for them on a daily basis? And be specific. So in specifics, please, we don't, as evidenced by or some kind of specific. Instead of saying something like symptoms are improving, when we're talking about a wound healing well, now that's really not going to get very far, versus improvement is evidenced by less redness, tenderness, swelling, drainage. Instead of just saying the client is getting stronger, something like functionally improving as evidenced by or as witnessed by, whatever. Today she was able to dress herself, previously, or today she could brush her own teeth, that kind of thing. Describe your efforts to educate, and we're not just, the client, the family. Are they going home with a caregiver? And their responses. Because sometimes we educate and people just don't get it. So why? Why did that happen? So all of that is going to be looked for in our charts. All right, so when we start, we're going to start here talking about atrial fibrillation, very common in our senior population. What is atrial fibrillation? It's also, by the way, known as AF or AFib. It's a very irregular, usually rapid heart rhythm and rate. It can cause symptoms like palpitations, fatigue, shortness of breath. We're going to talk more about that in a minute. What is happening? The atria, the top two chambers of the heart, are beating chaotically. They are not beating in rhythm either with each other, nor are they beating in rhythm with the bottom chambers, the ventricles. And often, especially if this goes on, it causes the heart to pump blood less efficiently. So going to the basics, how a heart normally functions and pumps well. New people signing on, could you please hit the little microphone in the bottom left of your screen to mute yourselves? So I'm not hearing myself talk through your computer, please. Okay. Normally, the heart beats in a very regular rhythm. The heart is muscle, and like all muscle, it needs to be told. It needs an electrical impulse to work. Normally, the heart does this in a very regular manner. It starts in the top chambers. The heartbeat starts in the top chambers. It goes across in a nice orderly path, causing the top two chambers to squeeze together uniformly. That message, that impulse, is then sent to the bottom chambers of the heart, the ventricles, and those beat now together in a nice pump action. That's a normal sinus rhythm. And a lot of you do EKGs and see EKGs, and when you look, I think I can get my little arrow here. So what you're seeing right here, that's the atria. It's a nice little beat going on, and then the ventricles beat, and then they rest. The atria beats, ventricles, nice little rest. But in atrial fibrillation, in atrial fibrillation now, those electrical impulses up here at the top are very chaotic, as you can see. The impulses don't come from that one nice little spot, that SA node. They're coming from all over, causing the top chambers of the heart to beat very chaotically, or fibrillate. So you see in that bottom EKG, all this wavy line stuff, that's the atria just beating very erratically, and they're not giving a good squeeze when they do this. There's also not a uniform system for those impulses to get to the ventricles. So you see the ventricles are beating at very irregular rates and rhythms also. So that is atrial fib. That is why when you listen or feel a pulse, you're getting very erratic. Also, when you listen, you may hear more than you're feeling, because some of these ventricular beats are not well fed by the atria and are not strong enough to make a pulse. So that's why it is important, especially in AFib, to compare what you're hearing to what you're feeling in the pulse. What are the symptoms? Oh, yay, no, sorry. Clicker's working now. Okay. Symptoms of AFib, they can feel this in their chest sometimes, palpitations. It's more just an awareness of the heart beating inside of you. Sometimes it can be very irregular. Sometimes it can be very uncomfortable. Sometimes they'll say it feels like a flip-flopping in their chest. Because the heart output can be decreased because of atrial fibrillation, symptoms like weakness, reduced activity tolerance, fatigue, lightheadedness, dizziness, even shortness of breath, and can be present. And some 35 to 45% of people, their atrial fib is just found almost on accident. They never had symptoms strong enough to feel the need to report. So some people are walking around with AFib and they do not know this. Thank you. Is that a problem? It absolutely is, which we'll show you that in a second. Who's at risk? Who's at highest risk? The older you get, the higher your chances are of atrial fibrillation. We know as people age, more and more people get atrial fibrillation. There is a big correlation between high blood pressure and atrial fibrillation. Heart failure, some atrial fib, if left uncontrolled, can lead to heart failure. And often people with heart failure go into atrial fibrillation. Ischemic heart disease, poor blood flow to the heart, often causes atrial fibrillation or leads to atrial fibrillation. We know people with obesity, sleep apnea, diabetes, hyperthyroid, chronic kidney disease also have a higher propensity to atrial fibrillation. And those last ones, sometimes controlling these, like getting someone who has sleep apnea on a CPAP or BiPAP, can often reverse atrial fibrillation, or controlling someone's hyperthyroidism can sometimes reverse atrial fibrillation back to a normal rhythm. All right, why do we even care about this? People with atrial fibrillation have a very high rate of clot forming and then throwing those clots to the body. We primarily think about a stroke, but also that clot can go to the lungs and be a pulmonary embolism, or get outside to the limbs and be a deep vein thrombosis. We already said AFib can often lead to heart failure. If nothing else, you're leaving someone sitting there with those very troublesome symptoms that we just talked about, like fatigue or that pounding in their chest. We also know people with atrial fibrillation, whatever else they have going on, they have more complications and often die earlier. So we want to control this. Okay, why do people with AFib have these clot problems? As I said, those top chambers of the heart here, what this, I hope you can see the little arrow, but if you look at the far left picture, now what those arrows are representing is actually the blood flow within the atrium. That blood is having a chance, it's not just going in and getting pumped out, it's sitting in there. When blood sets, it clots, or it has a chance to clot, it has a propensity to clot. So you look at the next picture, that's what you're seeing. These are clots forming in the right atrium and the left atrium. These clots can break off, and then if they're right atrium, they go to the lungs. Left atrium, they go out the aorta, go up to the brain, stroke, go out to the body, DVT, or you can throw a thrombus to your kidneys and have an ischemic kidney. They can go lots of places. This is also when people who are in and out of atrial fibrillation, which happens a lot, you have some people who are just, a lot of our folks by later in life, they're straight atrial fibrillation or persistent or chronic atrial fibrillation. We have some people who go in and out of atrial fibrillation. And sometimes we think, well, that's better because they're not constantly in AFib. But when people go back, they're in AFib, these clots form, and now they have a good, strong, regular heartbeat and a good, strong contraction of the atrium. That is what really puts them at risk of pushing out one of these clots. Okay. So what do we care? Like we said, one of our very first thoughts, especially when we first find atrial fibrillation, sure someone does not throw one of those clots and have a stroke, or a PE, as it may be. So we'll probably get them on an antithrombotic medication. Just really quickly as we talk here, antithrombotic, anticoagulant, platelet inhibitor, what are we talking about? Thrombotics are like the umbrella term. And underneath that is anticoagulant or platelet inhibitor. So you'll see like anticoagulant would be warfarin, low molecular weight heparin, Lovenox, Xarelto. Those are anticoagulants. And that tends to be what people on with straight AFib go on. Platelet inhibitors, aspirin, clopidogrel, which is Plavix, Ticlid, Agranox. Those are platelet inhibitors. They're both out there to try and prevent clotting, but they're two different classifications, just to cover that a little bit. But when folks are on these, monitor appropriately. So we know, with warfarin, so you see someone who has atrial fibrillation, one of your first thoughts should be are they on an anticoagulant, and what do I need to monitor for that? So do they need an INR? For any and all of these, we have to watch for signs and symptoms of bleeding. So do they bleed extensively from a cut, from oral care, bruising, changes in urine color, or signs of blood in their stool? Have to really be concerned with any kind of head trauma, and especially post-fall care. If someone is on one of these antithrombotics and they hit their head, we have to be very cognizant of bleeding to the brain issues. And we'll often send them out for a CAT scan. So we'd like to try and get them back into a normal heart rhythm. That would be ideal. We can do that. There's medications. You could do it with a cardioversion. You could do it with medications and a cardioversion, or an ablation. Most often, our folks, we've decided this is where they're going to be. They're going to live with this atrial fibrillation for the rest of their lives. So now what's our goal? Is to try and keep that heart rhythm normal. It's trying to keep them from going into into heart failure, trying to keep them. So we're going to watch those signs and symptoms of heart failure, and then going to help them manage symptoms like they're lightheaded. So what do? Teach them to rise slowly, teach them to stay well hydrated, those types of things. So other things we need to do. What about those co-contributors? Like we said, do they have thyroid issues, sleep apnea, kidney disease, high blood pressure? Make sure those are all well managed. Lifestyle, especially early in atrial fibrillation, these are very sensitive to stimulus. So some people can resolve their atrial fib just by stress management or watching their caffeine intake. And we know obesity can also enhance atrial fibrillation, so weight loss as appropriate. So what do we have to do now? We have to show that we're doing all of these things. So you have to document, what are you getting for that apical heart rate and rhythm? Watch their blood pressure. What are their signs and symptoms? Are they having any palpitations? Are they having any of those things we talked about? What are you doing for the person on an antithrombotic of any kind? Which means you have to document that, there were no signs and symptoms of bruising or excessive bleeding from fill in the blank, an injury, a sore. And then monitoring the labs, reporting those labs, and following up on those labs as appropriate. Don't forget about education. We have to let the family and the client know about how to manage this atrial fibrillation. If they are having those symptoms, what do we have to tell them about getting up slowly? What do we have to tell them about using razors if they're on antithrombotic? Let them know about the rate control, what to watch for with that bleeding. You know, we said the same things we watch for. Tell them all the things we watch for and remind them things like, you know, blood in urine may not be bright red, it could be tan, or stools. What does a black stool indicate? Those types of things. Talk to them about watching out for edema and fatigue, watching their heart rates, because atrial fib can make their heart rate go very fast, but too much of the medication we give for the AFib can now put them very slow. Talk to them about signs and symptoms of a stroke. Those lifestyle modifications we talked about, like limiting alcohol or caffeine, smoking cessation, warfarin and vitamin K dietary restrictions, watching those green leafies or green tea. And do they need a sodium restriction? That would be based on, are they having those heart failure symptoms? So all of that is the package that we need to show for PDPM what we're doing for AFib. Heart failure. It's a chronic condition, usually progressive. Well, it's gonna progress. Our goal is to limit the progression when we're treating heart failure. The heart muscle is not pumping enough blood to meet the needs of the body. That is the definition. It's a syndrome. What does that mean? It means that we diagnose heart failure based on symptoms. What are we seeing? What is happening? As opposed to a disease like atrial fib, I can do an EKG and tell you you're in AFib. I can draw your blood and get a high blood sugar and say you have diabetes, but syndromes are diagnosed based on symptoms, okay? So the heart's not pumping enough blood to meet the needs of the body. As that is happening, the body sends out signals that it needs more blood. So the heart tries to compensate by beating faster, or it tries to pump harder, but that muscle is weakened, and beating faster or harder is going to just further that weakening over time. Just a very quick kind of synopsis of heart failure there. There are different types of heart failure, and you'll see this in your ICD-10 charting, diagnosing also. So we'll talk about, they describe it as systolic versus diastolic heart failure. In other words, the pumping, systolic. The heart is not pumping well. Diastolic means that the heart is not resting well. Usually, why is that significant? That's when the heart fills. So if the heart is not filling well, it's not going to be able to pump well. Left-sided versus right-sided heart failure. Left side of the heart is what pumps blood out to the body. So that is often you'll see more fatigue with these folks. Pedal edema in these guys because the flow is not strong enough to bring that fluid back up. Right-sided heart failure, these guys primarily start by backing fluid up into the lungs or the liver, then maybe the belly, then to the lower extremities. Left-sided heart failure often leads to right-sided heart failure as it goes on. Acute heart failure, we're not going to be seeing a whole lot of that. That means something happened that can be maybe reversed. Sometimes like a virus to the heart can sometimes, we can reverse that heart failure, or some kind of toxic exposure. But most of our folks will be chronic. In other words, they will have some degree of heart failure for the rest of their lives. Who gets heart failure? A lot of people. What makes them susceptible? High blood pressure, uncontrolled high blood pressure. It's not exactly proven cause relationship, but we do know 75% of people with heart failure had or have hypertension. So that's a pretty big coincidence. Diabetes increases your risk of heart failure on a number of pathways. Coronary artery disease, electrical abnormalities, specifically, we talked about atrial fibrillation there. A lot of congenital defects can predispose the body to heart failure, the heart to heart failure. Thyroid disease, there it is again, the thyroid and the heart. Infections, bacteria and viruses can invade the heart muscle and cause it to weaken. Heart failure. Alcohol, drug abuse, HIV, and cancer medications can all be toxic to the heart, leading to heart failure. We know this. How do we, well, one, how do we diagnose this, but also how do we recognize that someone's heart failure may be decompensating or they're developing heart failure? Newer worsening symptoms like dyspnea, shortness of breath on exertion, more so than the day before, more than their normal. They have to stop and catch their breath in conversation because just conversation is causing problems breathing. They can't lay flat and breathe well. They need pillows or their head up. That's orthopnea. Their O2 sat may be going down. They have cough, wheezes, crackles. Why is that? Like we said, if the left side is not pumping well, fluid is backing up to the lungs, pulmonary edema, or edema to the body. And as we said, it's not always just looking at the feet. It could be to the hands. It could be to the sacral area or the belly in that area, especially if they're not feeling good and they're in bed all day. We watch weight gain. We monitor weights on people with heart failure. Chest pain, chest tightness sometimes, fatigue and decreased activity, tolerance. You can see anxiety. You can read there. The older people get, more often their symptoms are very vague. And so it will often be things like someone just feels a little punk today. They don't feel like getting out of bed. They're, a little foggy brained. We have to think and work through our critical thinking skills with those, but consider heart failure. This I just put in there really quick to show why it's important to notice this, because it can be improved. Here is someone on the left side. This is a chest x-ray of someone with pulmonary edema. They're in decompensated heart failure, and with treatment, this is an x-ray, I think it was just a couple days later, the x-ray on the right. Someone who was treated and got that heart pumping better, body working better, fluids off, and look at those lungs. That also helps you realize why the shortness of breath issues and those types of issues in people with heart failure. So what do we have to do in our care and documenting for people with heart failure? What is the heart affect? Your whole body. So what do we have to assess? The whole body. But again, paying attention to that apical heart rate and rhythm. They may have AFib, or they may develop AFib. Asking about chest pain and respiratory effort, cough, lung sound, shortness of breath, and can you breathe okay when you're laying flat? Watching for that edema, or documenting no edema. That's an important pertinent negative when you're looking at someone with heart failure. No edema noted is a good thing to note. Document. We're going to watch weights, skin color. Diaphoresis often is an indication of cardiac issues. Again, functional ability. Heart failure can really decrease people's abilities, people's energy levels. So what is their functional ability and the level of assistance needed? Any changes in mental status and that. And if you do notice changes, who did you notify? What did you do? And how did the client respond to that? We need to understand our daily management of someone with heart failure. Medications, daily administration of those medications is very important. Missing morning meds can sometimes have someone with end-stage heart failure decompensated by the afternoon. So really watching those medications, educating the person on that, understanding that if you have someone who's sick and nauseous and can't take their morning meds and they have heart failure, we better watch that person very closely and possibly be calling the practitioner very soon, because we do not want them to be decompensating by that afternoon. Changes in dosing, medications adjustments. We need to keep a close eye on people. How did they respond to that? Did we increase their water pill? How are they doing? Again, people with heart failure will very often be on one of those antithrombotics. So we're going to have to monitor for all the things we talked about. Drug levels. Digoxin, I think about. Heart failure is one of the few times we're going to see dig much. Watching their vital signs very closely. If you printed out the pages in the packet, you should have the Interact Care Path. And if you look through that Interact Care Path with me just really quickly, it guides us through the thinking process. You know, it talks about what are the symptoms of heart failure? What do you do when you notice these symptoms? You take those vital signs. Again, watching that blood sugar, thinking about the whole person. It gives you a little guidance about when to be concerned about those vital signs. If you have someone come in with heart failure, please get their parameters for their blood pressure and heart rate, because they'll often be running a little outside of what we typically think of as normal. And then, like it says, goes through. These are the signs and symptoms you should be thinking about evaluating. If you're seeing this, please notify the practitioner immediately. If you're not seeing these, you know, continue to monitor and consider some of these other situations. Do we need to call? Can we get a chest x-ray? Yes, we can do that. We can get that done in any of our facilities. Do they need to go to the hospital? Maybe not. Work through the Interact Care Path to see what we can do to help manage in facility and prevent a minor decompensation from becoming a major one. What do? We want to promote quality of life, right? We're not going to cure their heart failure, so we want to promote the best healthy heart failure life they can have. Maximizing their functional ability. So we encourage rest breaks. Don't, you know, try to do everything at once. Do little bits throughout the day. Family and client education and how were their responses. Tell them what to watch for, all the things I told you to watch for. My shoes are tight. What does that mean? Let them know. When this happens, what does it mean? How do we respond? And when do we report those? And if we're sending them home, they need to know who to call when they have these. Medications, why are they taking them? How to take them? Stressing to them not to miss medications. Talking to them about lifestyle modification, tobacco cessation. All of these things here can help. They may or may not be a sodium or fluid restricted diet. That depends what is their symptoms and what has been ordered. All right. Coronary artery disease. So here, well, coronary heart disease. Let me just backtrack a little bit. Let's go through some phrases here, because even in medical literature, you will see things worded and spoken of differently. So it's just in the fact sheet, I put a little bit about this in. So coronary artery disease is just that. The arteries to the heart, which you see in this picture here, see the arrow? These are the arteries to the heart. They are feeding the heart muscle blood. It's a muscle, it needs blood and oxygen just like every other tissue in our body. Those arteries can be diseased in many ways. Just because the arteries are bad does not necessarily mean it's affecting the heart yet. So you may hear people, I have coronary artery disease, never had a heart attack. Well, because it hasn't affected their heart yet. But then when that artery disease gets to the point of affecting the heart, they will call it coronary heart disease. You may also hear the term ischemic heart disease. So in other words, heart disease was caused by ischemia or poor blood flow to the heart, versus some of the heart failures we see had nothing to do with blood flow. They can have completely clear coronary arteries and still go into heart failure because of other issues. ICD-10 diagnosing, you'll see atherosclerotic heart disease most often, or arterial sclerotic heart disease, and then all kinds of subcategories of that. So ischemic heart disease, arteriosclerotic heart disease, and coronary heart disease, they're talking about a weakened or diseased heart muscle because of poor blood flow. I hope that helped. And so we see the bigger picture on the right, coronary artery disease, the buildup of plaque, and then a clot comes along and blocks that little bit of lumen that was left for blood to flow through. And now blood is not getting to an area of the heart, and muscle without blood and oxygen is going to be damaged, possibly permanently. So what do? Coronary artery bypass graft is an option. And that's what we're talking about. So they take a piece of vein, usually, or the most common is the saphenous vein. That's the big vein in your leg. That's why you see that big incision in someone's leg, but they can also harvest veins from the arms and other areas. But they take that piece of vein and they connect it up here to the ascending aorta to get some blood flow and bypass. They go beyond the area of the clot to continue blood flow down to that area of muscle. Coronary artery bypass graft. That is why this is often what you see after surgery. The incision down the chest to get to the heart that goes all the way through the sternum. They spread the ribs and access the heart that way. You will often see underneath that incision little holes. This guy had nice little holes. Ours are often bigger. Those were chest tubes to help the blood flow. As blood build up after surgery around the heart, that helps it drain right after surgery. So that's what the little holes there are. And then the leg, as you see, sometimes now you'll see just the little incisions at the top and bottom where they cut and then pull the vein out, or they go all the way down to get that. Those are what those incisions are about. All right, what's the risk? Who do we need to keep the closest eyes on when they're coming to us after bypass surgery? Who do we worry about having the highest risk for complications? It seems kind of like the more complications someone had in the hospital, the more risk they are for having complications with us. If you see someone who, had bypass surgery 3 weeks ago and they're just getting out to us now, something in your head should say, something went wrong here. I need to keep an eye on this person. If they have poor liver, kidney function, diabetes, both healing wounds. We know people with diabetics, wounds do not heal well. Remember, the heart was also surgically operated on. So the heart has to heal as well as the legs, the chest, and all of that. People with lung disease, obesity, and both the strain on the heart for obesity, but also we know people with obesity, surgical incisions have high infection and poor healing. The older someone is, generally the higher complication risk. What do we need to do for our people after CABG? Assess, intervene, monitor, educate, document, as with all of these. I kind of put these in priority somewhat, but it all depends on the person. So pain management, always. We're assessing pain every shift and not just asking, but then intervening if there is pain. Doesn't mean you're always just tossing them a pain pill. What about comfort measures, teaching them to move? Monitor their response to what you did for their pain and document how they responded. Educate family and the clients, and if they have caregivers, about early reporting of pain and the benefits of pain management. How, we manage your pain well, we can keep you moving. We can, improve your function and your strength and decrease your risk of pneumonia and all of those great things that getting them moving and controlling pain does. Pneumonia is a high risk after bypass surgery, especially if they also have COPD or other lung disease with it. So you're really watching lung sounds, the respiratory rate, shortness of breath, all of the things listed there. How do we help prevent this? Well, how about that incentive spirometry they came to us with? Please don't shove it in the bedside drawer and find it on discharge. Keep it at the bedside. Remind them to use it. Teach them cough and deep breathing exercises. Teach them about splinting their chest if they're having chest pain when they cough. Holding a pillow up, something. Keeping them moving. And of course, documenting. Documenting signs of pneumonia or documenting that lung sounds were clear. Another pertinent negative. We're going to watch that heart rate and rhythm because heart surgery can sometimes bring on atrial fibrillation. So we need to watch for that because now we'll have two issues going on. We have a new surgery and a new atrial fibrillation that we need to take care of or at least anticoagulate for. And sometimes that AFib caused by heart surgery may resolve later as the myocardium, the heart tissue, heals after surgery. Watching for chest pain. Things can happen. Just because we put that graft in there doesn't mean it works. Doesn't mean that they don't clot it off. So watch for signs of chest pain. Watch for signs. We know they have poor blood flow to the heart. Remember also, in our population, diabetic, elderly, women, they may not have chest pain if they have another heart attack, MI. So what will they have? Watch for signs of heart failure. Watch for, jaw pain, back pain, lightheaded, confusion, that type of thing. We're going to monitor for edema because many people with bypass have heart failure. They also got a whole lot of fluids in surgery. So we want to watch edema, again, not just to their feet and legs, but hands and trunk. Pay special attention to where the graft site was taken from. Remember, they just lost a part of their peripheral blood flow. We just took a vein out of their leg. So they may, and usually do, have a little more swelling to that leg, but we need to really monitor that graft site. And then, of course, document. They have wounds. Please, like I said, don't say wound looking great today. No, what's their color, temperature? Is it approximating any swelling, drainage? Signs and symptoms of infection, as in no redness or drainage. As evidenced by that type of thing. They're also a high pressure injury risk because remember they have this extra edema, extra fluid, and they're not moving so well. Puts you at a very high risk for pressure injuries and wounds. So we need to assess it. We also make sure they reposition. How do we keep the skin healthy? Hydration, nutrition, good skin care, barrier creams when appropriate, report changes, talk to CNAs about letting us know these things, and the clients and the family, and we document. Thrombosis, risk of clots is pretty high after bypass surgery. They will probably be on either an anticoagulant or platelet inhibitor. So again, we're watching for all those signs of clots, looking for DVT, PE, or stroke. Document, like it said, document improvement as well as worsening. Medications, can't stress the concern with antithrombotics enough. So again, we have that. Their cardiac meds, knowing and understanding what they're for, why they're there, watching their heart rhythm. Again, a lot of these guys are going to come to us on diuretics, their water pills. Some of it is because of all that extra fluid in surgery, and we may dry them out, so we have to watch and be concerned about dehydration. And even if someone has swelling in their feet, they can still be dehydrated intravascularly. So we're watching for things like low blood pressure, especially on standing, or dizzy or lightheadedness when they stand. They need good hydration to keep wounds healing and their body going. And don't forget comorbidities. Controlling their lung disease, their diabetes, watching their renal and liver disease, and what other things are going on. Because so often we'll get someone after bypass and be so worried about their bypass that we let their COPD get out of hand, that type of thing. Educate. Educate, educate. And remember, a whole lot of the campuses, you guys have the Pritchett and Hull teaching tools. Talk to your DONs about how you can get your hands on those and use those. But please don't just hand someone a piece of paper and say, read this. Go over it with it and make sure they understand. Because remember, part of your documentation needs to be their response to this education you gave them. So, goals for discharge home for anyone, but you get someone in after bypass, generally the goal is they're going to go home, or they're going to go live with a family member, or we're sending them to assisted living. We need to think about those goals from the first day they walk into our doors, and how are we going to meet those goals and make this happen? What is their ADL ability when they come to us, and what level do we need to get them to for them to be able to go home or go to family? How much assistance is needed? What are their signs and symptoms of strength? So, signs of strength. Again, as evidenced by ability to self-transfer, ability to self-ambulate with walker to bathroom with supervision only, versus, they were gait belt assist before, that type of thing. Education, we talked about that. Talk about everything I just told you, how to monitor their wounds, what to watch for with those wounds, about blood pressure and blood sugar, and why controlling their sugars are so important when it comes to healing. Wound care, if they need to go home with wound care. What to monitor, and then when and to whom they need to report. Who do you call? Because so often we'll say something like, okay, if you gain 3 pounds in a day, that's bad, you got to notify someone. Well, who do I notify? Do they have a cardiologist? Do they call their primary care practitioner? That type of thing. And then again, lifestyle modification. What do we need to do to be the healthiest person we can be? If they are on warfarin, do we make sure they understand about dietary high in vitamin K? And that is what we want to prevent. There is a beautiful, healthy heart on the left, and on the right, we have, that is a dilated heart failure heart. Let us open it up to any questions. Please type in.
So somebody had a question about this slide with the left and right sided.
Okay.
If you could just explain left and right sided. Backs up to the lungs, right? Because it was confusing.
Is there any way to go back? I'm sorry. Is there any way to go back to that slide? We had someone, I guess I did a very poor job explaining left and right sided heart failure. The left side of the heart, the left ventricle, that is what pumps blood to your body. That is the main workhorse. It receives blood from the lungs. So if the left ventricle is not pumping forward well, pumping blood out to the body, if it's not going forward well, it's going to back up. And the first place for it to back up is into the lungs. So that is where you can get pulmonary edema, and that is why it is so important to assess those lung sounds. The poor forward pumping of the ventricles causes those symptoms of foggy brain or lightheadedness or just poor activity tolerance. Was that helpful? And then the right side, remember the right side of the body, the right side of the heart takes blood from the body and pumps it to the lungs. So the primary issue there is if the right side is backing up, the first place you'll see back up, well, practitioners will look at the jugular vein, but you'll see issues like there could be backup into the liver or abdominal, may be the first place. They may have big abdominal edema versus not as much in the lungs. I mean, in the legs, sorry. I pointed to my legs, I said lungs. Anything else? Okay. All right. I am not seeing or hearing from anyone else. And you have that first slide. So if you do have questions later, you do have the first slide with Linda's email that you can contact if needed. If you did not get all of the handouts, please check with your director of nursing or check your email attachments to see if they're with that. All right. Well, thank you very much for your patience in working through our very first webinar presented from your very own education department. Thank you and goodbye.